So I'm going to be as quiet as a mouse. I'm not going to say anything this session.
That'll be hard for you to go.
It's going to be extremely hard.
We should wait. Wait a few more minutes. It's only just turned 5. Maybe we could just introduce who's there. It's hard to see you guys in the room. Do you guys mind just introducing yourself? So I'm Matthew Rickard. I'm from Sydney. Who's in that room? Is that Rooney?
Yes, hello. Hello, I'm Scott.
Hi, Scott.
I'm Stallone, surgical registrar.
Okay.
Okay, so I'm gonna present the 2 cases that we had. We came across at the surgical outpatient clinic, and then we took them in for endoscopy and then the surgical intervention. So 2 cases that I'm gonna present today. So next slide. Yeah, so the first case is a male, 22 years of age with hematochezia for almost a year, also associated with the chronic constipation. So there is no background illness of, there's no background of any illness. However, he came to the surgical outpatient clinic because of the altered bowel habits, which associated with PR bleeding. Yes, so there's no other significant history on those the past medical or family or the surgical history. So on examination, is cachectic looking male, slightly pale. There is no lymphadenopathy. There's no significant findings on the chest. However, the abdomen is slightly distended, but there is no mass palpable. On the rectal examination, there is no perianal lesions on the external. However, there is a very tight anal tone and can felt mass on the rectum, and also connoted blood stain on the glove as well. So it's pretty very low lesion as per rectal examination. And so we booked the patient for colonoscopy, and the findings of a fungating rectal mass. It's about less than 5 centimeters from the anal veg. Also managed to allow the scope, but then there's a complete stricture proximal to the mass because of the, I think because of the extension of the mass. So the endoscopy procedure is incomplete. However, we took multiple biopsies and we sent for histology to Royal Brisbane. So that's some of the pictures from during the endoscopy. Yeah, next slide. Next. Yeah, so we sent the patient home. However, as expected, he came back with obstructive symptoms. And so because we are still waiting for the histology result, we prepped the patient for just a Hartmann's procedure, waiting for the histology. So a couple of weeks later, the histology results came back with a rectal lesion, adenocarcinoma. So that's the histology result from Royal Brisbane.
They are the biopsy results from the colonoscopy, not from the operation, is that right?
Yes, yes, yes. From the biopsies are from the colonoscopy. Yes. So next slide. Yes, so after we've got the histology result, confirmed of adenocarcinoma, we discussed with the patient and the family regarding AP resection because the lesion was quite low. It's less than 5 cm from the anal veg. However, they refused and then lost to follow-up. And then he represented again just 2 months ago with perianal pains, also slightly loss of loss of weight and slightly pale. However, the colostomy functioning normally. And now from the PR, it is a stenosis or tight anal opening. I cannot put the finger through. It's an obvious protrusion of the mass through the anal opening. And now finally agrees for AP resection. And so for us here, we only do X-rays and ultrasound scan. So we've reinvestigated the patient again, noted the chest X-ray is normal and our ultrasound scan is also normal. There's no metastatic lesion to the liver or the para-aortic nodes. And so we do a clinical staging, with the modified Duke's criteria. It's of stage B. And then we took the patient in as planned for a AP resection. However, intra-op findings, the fused pelvic organs noted multiple omental lesions and also is a lesion on the liver as well. And so we just, open, close up, and just with the colostomy as a palliative case.
Yeah. So Rooney, at your first operation, you said Hartmann's. Did you just defunction him above the obstruction? What was the first operation? Was it just a loop colostomy above the obstruction?
Yeah, it was just above the lesion.
Right. So at the first operation, no attempt was made to resect. It was just to defunction the colon above the obstruction. Is that right? Yeah. And was that done as a mini laparotomy or just a trephine? How was that done?
It was just a mini laparotomy.
Yeah. Okay. And was there any evidence of peritoneal disease at that procedure with omental disease or anything in the peritoneum?
When we went in, it was all clear.
All clear then, yeah. And sorry, how long was it between then and when he came back? I wasn't sure of the dates.
It's about a month now, about a year.
A year.
We saw the patient October of last year, and he came back, 2 months ago, so around July, August. Around 10 months from the first presentation.
Yeah. And at his, when you first saw him, at that first rectal examination, any further comments then about whether it was, was it circumferential and did it feel fixed at the time? How did it feel at that first presentation?
It was circumferential, fixed and slightly very tight anal tone, like more like almost a stenosed, when you put a finger in, but it managed to do a PR, but it's a bit of tight anal tone. It's a circumferential mass, yeah.
Yeah, I guess it's likely that this was reasonably locally advanced even at his initial presentation. And perhaps you're never going to win with this guy because it sounds like if he was cahectic and he had a circumferential fixed tumor at that first stage, you may not have been able to change the natural history even if you'd removed it then. And at his first presentation, was it discussed sort of doing an APR acutely when he presented then or not?
Yeah, I think we've sort of discussed with the family, even for the Hartmann's procedure, they really hesitated as well. Until he noted fecal, coming out through the NG tube. That's when they opted for the Hartmann's procedure. But yeah, for APR, they sort of hesitated at the first instance.
Yeah. But okay. I mean, but when you say Hartmann's, you actually just mean a colostomy, don't you? Because a Hartmann's means you resect the tumor.
Yeah, just the colostomy. Yeah.
Yeah. Okay. So there was reluctance towards any stoma, and especially a permanent stoma, from early on. Is that right?
Yeah.
Yep. And do you have any other access to? You probably don't have access to radiotherapy or chemotherapy, do you, or not?
We have chemotherapy over here.
Yeah. Do you have access to radiotherapy? No.
No.
No. Yeah, I mean, I don't know what you think, Gary. It sounds like this guy unfortunately presented pretty late from the beginning, and it's just progressed with time. He's very young to have bowel cancer with that, and no significant family history, you said?
Yeah.
No.
Gary, if you're talking, you're on mute.
I think a defunctioning colostomy was a very good operation in someone presenting with acute feculent vomiting and large bowel obstruction. To try and do a resection acutely would have been, I think, quite tricky and perhaps perilous. I was just a little bit unsure though, Stallone. Were you saying that he had a fixed circumferential tumour on the first presentation? Okay, yeah. And the cahexias, I mean, by the time you're cahectic, I agree with Matt that it's very likely that he had disseminated disease back then. Easy to say in retrospect.
Like I said, during the endoscopy, because of the fixed circumferential mass, you cannot even complete the colonoscopy procedure.
I guess his only chance was what you did initially, just to defunction, do a colostomy above it, was ideal. So you get rid of his obstruction, and then ideally you decide whether it's resectable. If it's a low fixed tumor, it's going to be difficult and potentially, very dangerous resecting that. But obviously then he progressed even further when he disappeared. Has been any place for palliative chemotherapy in this situation?
The drugs that are available on the formularies aren't fantastic. So it's just 5-fluorouracil. So the response rate of 5-fluorouracil is not high, maybe about 20%, 20-25%. So it might buy a bit of time, and it maybe improve quality of life briefly, but the stronger drugs that we use now, like oxaliplatin, aren't yet available on the formulary. Yeah, but you can try some 5-fluorouracil. A better drug, I think, is easier to give is an oral form of 5-fluorouracil, which is capecitabine. That drug has come down in price.
I wonder, Ricky, are you able to mute? Because it sounds like a bomb's going off. I'm sure it's your kids, but sorry, go ahead, Des.
Yeah, I think oral capecitabine is now generic, and it can be managed, but it's got more toxicity than the 5-fluorouracil. Yeah, so I guess it's not available in the country.
Sorry, Des. Oral capecitabine is more toxic than intravenous.
Yeah, that's right. Yeah. So you've got to be able to manage that. Yeah. And we can't do infusion pumps yet in the islands. The cost of the infusion pumps is quite high, and to manage them as well. And if they have to do 5-fluorouracil infusions, they have to be admitted to hospital, which is not that practical for managing the colon cancer. So we're looking at bolus 5-fluorouracil and folinic acid. Yeah, it's what we did in the old days as well. And you can palliate some patients with that. I've suggested they use like a weekly sort of schedule to minimize the toxicity rather than give it 5 days in a row, the old Mayo regimen, which caused a lot of mucositis and diarrhea.
Yeah, I think this guy's situation is obviously grim. What's happened to him since? What's his situation at the moment?
Yeah, still around doing normal chores, but only complain of the perianal pains. Still up and about.
Yeah, unfortunately, his future is going to be significant, you know, pelvic pain as his disease locally progresses. And also because he's defunctioned, it may be some time before he actually dies if he hasn't got extensive metastatic disease. So it can be quite a painful way to go and difficult to palliate, really. How are you treating his pain?
Actually, he's doing well with some NSAIDs and paracetamol.
Yep.
Yeah.
I'm not
Matt,
sure. Sorry, go on.
Santi here. Just for educational purpose, maybe you should tell them how we treat the patient if that happened to be an Australian patient.
Yeah, okay. So this is a young man presenting with probable locally advanced disease from the onset. So he's had symptoms for 12 months and he's cachectic. So here we treat him as a locally advanced rectal cancer. So if he was obstructed, we would do a defunctioning colostomy above it, exactly as you guys did. So we would do a loop colostomy, probably an ab-carrion type colostomy where you staple it off and you've just got an end colostomy with the other end just sutured to the skin near the stoma. So that would get him out of trouble. And then he would be assessed with an MRI of his pelvis to see how locally advanced it is, and a CT of his chest, abdomen, and pelvis to see if there's any metastatic disease. If he had, I mean, he's a young guy, so we'd be aggressive. If he had locally advanced disease in his pelvis, we would probably give him what's known as total neoadjuvant treatment. So he would have some radiotherapy, and then he would probably have some chemotherapy, something like Folfox, and then it would be reassessed with a view to a resection. It sounds like he would require an APR because the tumour is very close to the anal canal. That's hard to tell unless you do the PR yourself. But so you would defunction him and then you'd treat him as much as possible with radiotherapy and chemotherapy to see if it's resectable. If at his initial presentation he already had metastatic disease, then he would probably be managed palliatively here. So he would possibly get some chemotherapy, some palliative chemotherapy. He'd keep his colostomy. As the local disease progressed, he would get, you know, appropriate analgesia, maybe involvement from a pain team. So I think we would approach him from the beginning, which may involve quite a difficult pelvic dissection, might even involve a pelvic exenteration if it was involving his bladder and prostate. And he'd often get, now the big rage is TNT, which is total neoadjuvant treatment. So I'm thinking that's what he'd get. From your very first presentation, when you did, you know, you did the PR and you felt a big tumour, that sounds like locally advanced rectal cancer if you've got a circumferential fixed tumour. What do you think, Desmond, in terms of either of those two situations? If, say, you had locally advanced but curable disease or locally advanced and metastatic disease?
Yeah. So, yeah, it was curative. We would probably go down the TNT approach. That's what we've tended to do now in the last year or so. So it's taken a while for everyone to come to that agreement. Palliative, I think we would probably still offer radiation down there because we've got good systemic therapies that can often hold the cancer for quite a long time, and they'll get into problems still with local progression in the pelvis.
Honestly, I think from what you were saying, this guy's days were numbered from the first time you saw him. So it was a matter of relieving his bowel obstruction, which you did well, and then handling the pain, really.
Okay.
Any questions or comments from the other people regarding that case?
One sec. You happy?
I think obviously this is always the problem with bowel cancer in environments where people don't get colonoscopies easily, the problem is always presentation with locally advanced disease, isn't it? In Sydney, you get a colonoscopy if you just cough.
That's one.
That's true. There's obviously we do a lot of colonoscopies. We have a bowel screening program where everyone from age 50 to 74 gets a fecal alcohol blood test every 2 years. So there's a lot of colonoscopies done, and we do pick up tumours early. Interestingly, we had a few patients present with a disease just like this towards the end of last year because they'd sort of stayed away from hospitals because of the COVID pandemic. So we've had some late presentations because of the pandemic and people being scared of going to hospital or people being turned away from hospitals. So that's been an interesting phenomenon for us. So you want to present this next one if there's no more comments?
Okay, so the second case is it's a male 50, quite similar presentation as the our first case as well. So altered bowel habits for more than a year. Seen by the team around August of last year. It was booked for colonoscopy, but then patient, however, lost the follow-up. And so he came back with worsened symptoms just a month ago. So it's almost a year from the last presentation. And now he's complaining of a painful defecation. So he came to the surgical clinic and we booked for a colonoscopy again. Next slide. Okay, so PR done was a very painful exam, so we cannot manage to put the finger right through the anal opening. And so even during the colonoscopy, it's also a very, very difficult because of the pain as well. So it's only managed to go up around 25 cm from the anal veg, and there's a mass noted. And so the procedure wasn't complete because of the pain and very tighter stricture.
Sorry, but so you got 25 centimeters, but the mass was in the rectum.
No, during the PR, you cannot really appreciate any mass.
Okay.
But only during the colonoscopy, we noted around 25 centimeters from the anal veg. Okay,
so just to be clear, the mass is at 25 centimeters from the anal veg.
Yes.
Yeah. Okay. Yep.
Yeah, so those are the images from the colonoscopy. And so he came back 2 days post-colonoscopy with obstructive symptoms. And so an abdominal discomfort and also abdominal distension as well. And so we admit the patient and plan for a laparotomy as well. Yeah, so only the obvious findings is abdomen was slightly tight, distended, also tender. And yep, that's the PR findings. So he came back with obstructive symptoms. So we are thinking of, again, defunctioning colostomy, and then similar with the first case, waiting for the histology result as well from the colonoscope biopsy.
Before you go on, I just want to be clear, because you've said rectal mass, but you've said lesion at 25 centimeters. So 25 centimeters would be in the sigmoid.
Sigmoid, yeah. I think it will be consistent with the intra-op findings. Yeah.
Yeah.
Histology result from the biopsies taken from the colonoscopy. So it's noted high-grade dysplasia adenomatous polyp. That's from the histology results.
And with that sort of histology result, that always makes me wonder, sometimes if you've got an obstructing lesion, you can't get biopsies from the center of it, and sometimes you just get biopsies from the edge of it. So even though it looks like a cancer, you may not be able to prove it. Is that what you guys were thinking with this biopsy result?
Yeah.
Yeah, so when we went in, there is a rectal, I think the sigmoid mass, which also invades the bladder anteriorly. And there's also a segment of the ileum attached to the mass as well. So because it's still, mobile, and we were thinking of defunctioning colostomy, but because the mass is pretty mobile, so we're thinking of a resection anastomosis as per the phase planned. So we managed to excise the mass, also involves the bladder, so we have to do a bladder repair as well. And there is a ileostomy done, defunctioning, a loop ileostomy done.
And was it sort of stuck just up on the dome of the bladder, the top of the bladder?
Yes, yes.
Yeah. Okay. So it was sort of sigmoid flopped down onto the top of the dome of the bladder.
Yeah.
Yep. Nice. And was that all done sort of on block? Were you able to take it all out as one piece, like bladder still connected to the tumor or not?
Oh, all of them were in one piece.
Yeah, beautiful.
Yeah, so we're still waiting for the histology result for this patient.
And how do you do your anastomosis with because it sounds like you did what we'd call a high anterior section, and you're defunctioning with an ileostomy. Do you do your just a hand sewn anastomosis, or do you have stapling guns?
Which is use of hands. Suture. We don't have staple at the moment there.
Yep, that's right. And so this tumor was reasonably high up and stuck on the bladder, and then you said there was also a bit of small bowel stuck to it as well, which you took on block. Is that right?
Yes.
Yeah, good. And when, assuming his biopsies come back as cancer, when would you plan to remove his ileostomy?
So at the moment, we are not so sure, but we were thinking of waiting for the histology, and after that, we probably start off chemo. When it's also
in terms of the ileostomy closure, my only comments would be I would leave it at least 3 months. And if you're going to do chemotherapy, I would wait till he's finished the chemotherapy, which might be 3 or 6 months. And I would also, prior to closing the ileostomy, I would check your join. We usually check it with a gastrographin enema. So I'm not sure if you've got that, but just gastrographin rectally and in a plain film, and make sure the join's not leaking before you get rid of the ileostomy. So that's something we do routinely. So we check the join, and I would usually also look at the join with a colonoscope just prior to doing the ileostomy closure. So make sure he's sort of at least a month post chemo if he has it, and check the join and then do your ileostomy closure. But Des, you might comment on the place of chemotherapy here. Let's assume his histology comes back as a node positive tumor, which sounds likely.
Yeah, we'd normally offer adjuvant chemotherapy because there's a substantial benefit in terms of reducing the chance of relapse and improving survival by giving adjuvant chemotherapy in this situation. And usually you want to get the chemo going within 3 months of the surgery. The effect is lost if you wait too long. And I think in terms of leaving the stoma, it sometimes helps if they get diarrhea. Having the stoma is easier to manage than if you close them up, before you get going with the chemo. But often it's a decision you've got to make with the patient patients may not like the stoma. We'll discuss with him the pros and cons of having early stoma closure.
And what chemo would you give, Desmond?
In this situation, it'd be 5-fluorouracil and leucovorin. And we recommend like a weekly schedule because the toxicity is less. So it's weekly bolus 5-FU and folinic acid. It's called the Quasar protocol. It's like a British protocol. And that's got fairly low toxicity. And it's for 30 consecutive weeks.
And say he was able to get that and tolerate it and complete the whole course, what's the survival benefit? Assuming it was a T3N1, let's say it was just say a node positive tumor, which is likely.
Positive. So, I mean, if you say like, the chance of relapse is about 50% if the node positive, then it reduces the chance of relapse to maybe 35%. Modest benefit, yeah. They're usually material to people, especially the young. And this is a node positive cancer, so that about the average statistics.
Yeah. I guess you said exactly what I try and remember, which is that you can improve survival by so your relative risk reduction is about 1/3, isn't it? So your relative risk reduction, whatever your stage is a 1/3. But if you're a stage C, you've got a 50% relapse rate. So 1/3 of 50 is about 16.6%. So that's your improvement. Whereas if you're a stage A tumor, your 5-year survival is about 95%. So even 1/3 of 5% is not worth it.
No.
So it sort of tips the balance, doesn't it, to be worth it for chemo in terms of the absolute survival benefit once you're a stage C tumor. Here we sometimes give what we call bad Bs chemotherapy. So maybe young people who are node negative but have particular features on their histology like high grade or lymphovascular invasion. Sometimes we give them chemotherapy as well. There's not huge proof of benefit for that, but we sometimes do that for young people.
Yeah. The benefit, if you quantify, it's only about 4 or 5%, so it's much less. There are large studies, looking at that, but the benefit's much smaller. It's not proportionate. It's less than proportionate for that stage. Yeah. And I was saying there's substantial benefits using the 5-fluorouracil. We use oxaliplatin on top of that to try and increase the benefit, but the additional benefit's only about 5%, for a lot more toxicity.
And the other interesting thing, what you guys did there with that patient was fantastic, because if you've got a locally advanced tumor like that and it's stuck onto any organ that they can do without, and you can get it out, you should take it out, because size in bowel cancer, size is not relevant at all. And if you can get that out, even if it means taking a bit of bladder or taking a bit of small bowel that's stuck on it, that's worth doing. Because some of these patients have massive tumors and they're actually node negative and they do really well. Whereas other patients, we see they'll have a tiny little tumor the size of a 5-cent piece, which is already spread. So it's about tumor biology rather than size. So if you're able to do an en-bloc resection and remove exactly what you did, remove the dome of the bladder, remove a bit of small bowel stuck on it, then that's exactly the right thing to do. And I think with these intra-abdominal tumors, that's very appropriate. That first case was a rectal cancer in a man, and locally advanced rectal cancer in men is very difficult because the pelvis is tiny and it doesn't take much for them to become unresectable. But really, the second case is a good example of treating aggressively surgically and doing exactly the right thing. How do people cope with ostomies in the Solomons? I think you guys are still muted. Gaz, can you unmute them or not?
Yeah.
That's better. So I was just asking how people coped with ostomies of any sort.
Yes, well, a lot of people don't like colostomies. So, and one of the big problems that we have is consistency of stomach bags. That is one of the issues that we have. So thank you, Gary, for sending the boxes of bags that came in the last container. But it takes it usually takes a while and a lot of talking and convincing for people to accept having ostomies.
Yeah, I think that support is the most important thing. Like, we have stomatherapists and we have a society, and as soon as you get a colostomy, it's free membership of the society, and they get their stoma bags for free and they get them delivered to home. So it makes a big difference, that support. I might, so any more questions, queries about those two cases? Because if you want, I can just do a quick whiz through rectal cancer management.
Yeah.
So can you guys see, what can you see now, Gary? Gary, you're on mute. Can you see that slide?
Yes, yeah,
yeah, okay. So assessment of rectal cancer. I think a bit of noise there. Assessment of rectal cancer. I think the rectal examination is actually extremely important. So, and probably possibly the most important thing, when you do a rectal examination, you need to think like a surgeon. So you need to be thinking, is this anterior, is it posterior, is it fixed, is it adherent, is it mobile, is it stuck to the prostate, and what is its relationship to the anal sphincter? So a surgeon doing a PR on a rectal cancer will be thinking one of two things: can I get this out? And if I can get it out, is it joint upable? So if we can do an ultra low joint, we can avoid a permanent stoma. So that's what you should be thinking with your rectal examination. And really, we do a lot of other tests, but you can get so much information just from your PR. So it's super important to pay attention when you're doing PR, and just think, you should be thinking two things: can I get it out? And can I join it up? And you get, honestly, I get most of my information from the PR, and sometimes you need to do that rectal examination as an examination under anaesthetic. You talked about your first patient being too tender to examine. That's quite common. So what we'll occasionally do is just do an EUA for the scope, and we'll have a good feel with the patient asleep and make a lot of decisions about them basically just on the PR examination. Obviously, abdominal examination is important to see if there's any obvious clinical metastatic disease or whether there's any peritoneal disease. As I said before, we would usually do a CT scan of the chest, abdomen and pelvis to see if there's any metastases. And we would, for our cancers, we would do an MRI or a rectal ultrasound. Usually we do MRIs. But if that's not available, you don't need that. And I think, honestly, the rectal examination is the most important thing. And the thing to realize is, if you can feel a rectal cancer easily, then it's going to be a challenging operation. So especially in a man, and especially in a fat man. In women, things are a bit easier. They've got a big pelvis. But when you can easily palpate a rectal cancer, that's going to be a difficult operation. Whether you're joining them up or doing an APR, it's going to be difficult. The anatomy is important. And I think you need to think, I think of rectal cancers as either extraperitoneal rectal cancers or intraperitoneal. So you need to think about that when you're doing your scopes and documenting it. But to think of the rectum as about 15 centimeters. So you've got your anus Can you all see my pointer? Maybe Gaz, nod your head if you can see. Can you see the pointer? Yeah. So you've got your anal canal, which is 3 or 4 centimeters. Then you think of it as 5 centimeters, 5 centimeters, 5 centimeters. The important thing to realize is that at the front, you've got your peritoneal reflection, which is probably in most people in the mid-rectum. So we really think of cancers as cancers in the extraperitoneum or intraperitoneal cancers. Intraperitoneal rectal cancers we treat just like colon cancers. So it's important when you're doing your PR to think about where it is, and if you are doing colonoscopies, to document how far it is from the anal verge. The best measurement is from the anal verge. And even that's poorly defined in the literature, but the anal verge is basically when you've got your scope in, whether it's a rigid scope or a flexible scope, the anal verge is, if you just part the buttocks a bit, is where the skin touches your scope. So that's the anal verge, and you should take your measurements from that. It's quite useful to measure them with a rigid scope in terms of management. And the other thing to realize is that, and this sort of displays that in cross section. So in the low rectum, there's no peritoneum. In the mid rectum, you start to get that peritoneum come down. And in the high rectum, it's just like the colon. So it's got peritoneum, not all around, but basically most of it's got peritoneum. So that's important to understand that anatomy, the difference between low, mid, and upper rectum. In fact, down here, there's not a lot of, these pictures are from a radiology textbook. There's in fact not a lot of mesentery at the front at all. But you can see low rectum, no peritoneum at all. Mid rectum, you've got just peritoneum at the front. Upper rectum, it's like the colon, you've got peritoneum around the whole thing. So that's a very important thing to realize. And the reason it's also important to realize, this is why low rectal cancers do worse. This is just a diagram to sort of display, as you get down to your low rectum, the mesentery kind of disappears. So the same size tumor there can involve that, what we call the mesorectal fascia. Whereas the same size tumor up here, it's like it's got this padding, and it takes a while for it to get through that mesorectal fascia. So low rectal cancers, whether they're treated with a permanent colostomy or with a resection, do worse. And it's because they're more likely to locally recur. So we give radiation to a lot of people with rectal cancer. And I know it's not available for you, but basically we do it to decrease that risk of local recurrence. So it's probably doesn't have a huge survival benefit, but it decreases local recurrence. And sometimes it makes these big tumors, like that first guy that you presented, if he'd had decent long course chemoradiotherapy and chemotherapy, it sometimes will turn it into something that you can get out. So we tend to give it for these extra, what we call extraperitoneal T3 and node positive tumors. So they're the people who get radiotherapy. Again, not an option for you, but there's a sort of worldwide, the treatment for rectal cancer is evolving. It's quite interesting because there's a group of patients who can be just managed with radiotherapy alone. So it's what's called this watch and wait. And I think that will probably, that group of patients will increase. And it may be in 10 or 15 years in developed countries that a lot of patients who got surgery now for rectal cancer may not get surgery at all. They may just get radiotherapy and chemotherapy. So that's an interesting thing to keep an eye on. In terms of the operations, I think this is important to realize what you're doing with rectal cancers. And I'm going to go show you this with with the aid of a picture. Again, that picture of the rectum, realize that, so this is a sagittal section. So that's your peritoneal reflection at the front. And you've predominantly got the mesentery posteriorly. So when we talk about, I'm sure you've read about the TME, so total mesenteric excision. That, I think that has become confused in the medical world because I think it's caused some people to treat upper rectal cancers far too aggressively. Basically, all the TME means that you dissect in this right plane. So there's a beautiful plane behind the mesentery here, right down to the pelvic floor. And at the front, once you crack through the peritoneal reflection at the front, there's a beautiful plane here. between the anterior rectum and the seminal vesicles and the prostate. So if you're dissecting in the correct plane, it's better from a cancer point of view. It's also better in terms of bleeding, because if you're in the correct plane, it doesn't bleed. And then you need to base your operations on where the tumor is. So this is the concept of TME. So with a low tumor like that, you want to take out all that mesentery and you want to chop it off right down here at the anorectal junction. But what you don't want to do is you don't want to treat upper rectal cancers with TME. So I'm just going to show you that with a picture, with some pictures. So if you've got a tumor up here, so hopefully you can see that the star is the tumor. So that's upper rectum. So for that patient, you don't need to go right down to here. Okay, you only need to get ideally 3 or 4 centimeters below the tumor, but you can cope with just 1 centimeter. So with that patient, your transection margin is here, just at the peritoneal reflection, and you're dividing that rectal mesentery formally. And then you can do your joint. These joints are harder to do when you're down in the pelvis hand sewn. We, as you know, use the stapling guns, which makes it a lot easier. It is possible hand sewn, but more difficult. And then if you've got a tumor in the mid rectum there, or mid to upper rectum, you only really have to go to there. If you can leave any rectum at all, the function for that patient is a lot better. So any rectal reservoir at all, if you can leave it, based on the pathology, then the function will be better in terms of their bowel function, their urgency, their frequency. So a tumor down here does need a full TME. So if you've got a tumor there, you actually need to get right below that mesentery and you need to put your stapler across here. So these ones are very difficult without stapling techniques, because we've got this beautiful transverse stapler. We mobilize up the rectum and we can just whack the stapler across right at the anorectal junction. And then we can do a circular staple joint. So these are difficult without stapling techniques. And these patients without stapling techniques probably need to have an abdominoperineal resection with a lower rectal cancer. And this is what I'm getting at. If you can leave some rectum, if you can leave a rectal reservoir, then you can just do an end-to-end joint. So what you guys did with that second patient, a joint up here, either with a stapler or with hand sewn, you do an end-to-end joint, they'll have reasonable function if you can leave enough rectum. What we tend to do, if we're doing a joint right down here, what I would do is do what's called a side-to-end joint. So you sort of turn the colon on its side and join it on, which creates a little bit of a reservoir. So that just gives you some rectal reservoir for the future and improves their function. And what you did with that second patient with a defunctioning ileostomy is very appropriate. So when you're operating acutely, that guy had a bowel obstruction. That's definitely that I would have given that guy an ileostomy as well. I would have potentially joined him up. I would have possibly done an on-table washout just to get rid of the stool. But doing a defunctioning joint in an acute situation is very appropriate. This is more an elective situation. So if we're doing an ultra-low joint with the joint right down at the anorectal junction, we'll usually do an ileostomy, and we'll definitely do it if they've had radiotherapy. If they've had radiotherapy, it makes their risk of a leak a lot higher. And if I'm doing a low joint, not an ultra-low joint, I'll sometimes do an ileostomy. And if I'm doing an elective high anterior, which is what you did on that second patient, I wouldn't usually do a defunctioning joint if it was elective, because then you've had time to clear the bowel out, and it's a lot different operation. So when to do an APR? So I think when you might be forced to do an APR might be different to me because of the staplers. But with us, if we don't think we can get a stapler below it safely and getting clearance, then they need an APR. A patient who's already incontinent, say perhaps a woman who's had lots of obstetric trauma, who's already incontinent, if you do a low joint, you'll make her life miserable, and she's better off with a permanent stoma. Or certainly if you've got direct involvement of the sphincter. So if you've got cancer eroding into the sphincter, then they need an APR. So as I said, that might be slightly different in your world than my world because of the staplers. But if you can't do a safe joint below it, they're better off with an APR, and they're better off having a proper APR where you remove the anus and you go right out to the sphincters. complications. So these are things that can happen. So sexual function, sexual dysfunction. So the hypogastric nerves are the nerves at the pelvic brim. If they're damaged, they get retrograde ejaculation. If you fiddle around, especially anteriorly next to the seminal vesicles and the prostate, and you interfere with the parasympathetic nerves, so they can get impotence. And there's a lot more urinary dysfunction than we think, and bowel dysfunction. So I think, Desmond, I might leave it there. Yeah, I've got a few others, but I'll leave it there so to give you a bit of time to talk about that. So, but I think with rectal cancers, the assessment is really important. And I really think a proper rectal examination, an educated rectal examination, thinking like a surgeon, can I get this out? Can I join them up? Is as useful as all the other stuff we do. Before Desmond talks, any questions about that? Okay.
Okay. I just wanted to check with our colleagues in PNG, Vanuatu, and the other places where the Kiribati, whether you've got access to chemotherapy. PNG. Yep. So just explain that in the Solomon Islands, Andrew Soma is training in medical oncology there, and we've got a chemotherapy unit where we've centralized the administration of chemotherapy. So as a result, we are able to deliver adjuvant chemotherapy in the situation of patients who've had curatively resected node-positive colon cancer. So I'll just run through a few slides. Yeah, so bowel cancer, this is a staging system that you've shown before in your slides of how deep the penetration of the tumour is through the wall and whether there's nodal involvement. So stage 3, or the old Duke's classification system, sees where it's involving the lymph nodes in patients with resected bowel cancer. And that's where the primary benefit of giving additional treatment is. So stage 1, as Matt mentioned before, has got a very good outcome, or Duke's A cancer, and surgery is sufficient to treat these patients. Patients with stage 2 and 3, so we mentioned the high risk stage 2 patients, where there may be a modest benefit of giving additional treatment. So high risk stage 2 would be patients who've got perforation of their tumour, T4, where it's involving surrounding structures, bowel obstruction, lymphovascular invasions, another factor which you may see on the pathology that puts into a high risk category. And stage 3, definitely there's a benefit, so where there's nodal involvement. And stage 4 is usually palliative treatment unless you can resect the metastases. So primary therapy of early colorectal cancer is surgery, and treatment in addition to the surgery is called adjuvant therapy. And so the situation is that most patients are cured by surgery if they have a resection of the tumour and there's no spread of the disease and they remain cancer-free down the track. And by spread, I mean in terms of micrometastatic disease having escaped into the circulation. So the situation where patients may not be cured by surgery is where you got the initial tumour and there's micrometastatic spread, which you can't pick up by imaging or by blood test. And these cancers can seed elsewhere in distant sites, and they show up as being metastases subsequently, and this can happen months or years down the track. So the use of systemic therapy soon after curative primary local therapy is called adjuvant therapy, and it comes from the Latin term adjuvare, to help. And this is a situation where there's significant risk of death from the cancer, and death is due to occult metastatic disease developing into overt disease, and where there's effective agents available with acceptable side effects to destroy the metastatic disease, the micrometastatic disease. My screen's, here we go, sorry. Yep, so there's a number of studies that have been done looking at giving chemotherapy. These are studies done in the 80s and late 70s, looking at reduction in risk of recurrence by giving chemotherapy after patients have had surgery. And the benefits mainly in the stage 3 or C groups. And the paper that really was the landmark study was called the Mortel study. It was done in America. It was called the Intergroup 003 study, where they looked at giving 12 months of fluorouracil. It was weekly fluorouracil for 12 months versus observation. And they also combined it with levamisole. Levamisole is an anti-helminthic agent. So it would add like it would be like a form of immune therapy. And they found that there was a relative risk reduction of between 30 to 40% in the stage 3 cancers. And so that kind of changed treatment. That's when we first started using adjuvant therapy in the late 80s or early 90s. And then subsequently studies showed that you didn't need the 12 months. So that 6 months worth of treatment with 5-fluorouracil and leucovorin was similar to 12 months of treatment. And it was subsequently proven that the levamisole actually added no benefit. So levamisole was taken out of the schedule. And there's no difference in using higher, lower doses of leucovorin. So to save money, low dose leucovorin is as good as using high dose leucovorin. And we've chosen a schedule of weekly 5-FU and leucovorin because it's got a good toxicity profile. And that's that Quasar protocol that we recommend that you use in your nations that can give the 5-fluorouracil. So established role in stage 3 colon cancer, 6 months of 5-fluorouracil plus folinic acid or leucovorin, and these are fairly standard now. These other slides probably aren't relevant because we can't obtain oxaliplatin, but it's a drug that we could probably get onto the formulary subsequently. So giving oxaliplatin in combination with the oral fluoropyrimidine for low risk stage 3 cancers, we can get away with 3 months worth of treatment. There's a study showing that 3 months is non-inferior to 6 months of treatment if you use that particular protocol, combination of intravenous oxaliplatin and oral capecitabine. That's something we can look at in the future. We can get those drugs onto the formulary for you and you're used to using the drugs. Okay, that's all I had to say.
Scott, did you want to, any questions for Desmond about that? Okay, so Scott, you're going to present your endoscopy data.
Okay, they're muted at the moment.
So you guys are muted.
I'm just going to present the 6 months experience that we have for this year, January to June. And it's upper GI and lower GI. So as you could see over there, for the last 6 months, January to June this year, we did a total of 238 endoscopy, diagnostic endoscopy procedures. And for the lower endoscopy, there were 46 of them that we did. The upper 192, totaling up to 238. Other variables, as you could see over there, I think total tumor yield was around 12.2%. There was one medical death. I think it was medical cause. No complications. Next slide. This is just a summary of the diagnostic upper endoscopy findings. I think majority of the patients were male, 66%. And I think for tumors or cancers of the upper GI, As you could see over there, esophagus, there were 5 of them, stomach 12, duodenum 2, larynx around 1. So I'll go into detail for the other others.
Is that picture someone who's swallowed a coin? What is that?
Oh, that's a picture of foreign body in the esophagus.
Yeah. That's a good, safe place to keep your money.
Yeah, some more money there.
Oh, that's not money. It's a ring, is it? What is it?
Sorry? Yeah, it's
quite lucrative.
All right, keep going.
yeah.
So,
Okay,
what was that? Was it a ring or was it money?
It's money.
Yeah, good.
Yeah, these are the results for the upper endoscopies. So there were 20 of them were cancers, all types, which accounts for 10.4%. Next slide. And for the esophagus, there were 5 of them, all histologically confirmed. 80% incident in men. Median age is around 61. For women, 63. These are some pictures, local pictures that we took in the endoscopy. Most of the cancers that came in almost completely obstruct. So we have to put in stents to allow them to have something to eat and drink as a palliative treatment. Next. These are some of the stents that we inserted. I think they were within the 6 months, we inserted 4 stents, and they're doing okay. Yeah, varicose bandings are common. I think we've done 11 of them the last 6 months. Next. Gastroduodenal cancers, there were 12 of them, 10 in the stomach and 2 in the duodenum, all histologically typed. And as you could see over there, 71% incident in men. Yeah. Median age is around 58, 59, 50 for women. Next. There's some pictures of tumor in the pyloric area and into D1, which we managed to just do bypass, gastric duodenostomy bypass. Next. For the colorectal cancers, there were 9 tumors that we found from the 46 colonoscopy that were done, which accounts for about 20%. 1 on the right, 1 on the left, and 7 of them low in the rectoanal area. So all of them are adenocarcinoma. 67% incident in men. Median age is around 62, 57 for women. These are some of the pictures that we took. So surgical procedures performed as a result of endoscopic diagnosis in this cohort. And from January to June, 60% of the operations were performed for cure and 40% were palliative, as presentation was quite advanced. So these are some of the surgical procedures that we did. I think that's basically what I was able to put together.
Wow, that's amazing that you've scoped 46 people and found 9 cancers, and you've done 192 upper endoscopies and found 17 cancers. That's just mind-boggling.
Yeah.
It's interesting because here we have there are certain indicators for quality of colonoscopy, and the 4 things that we look at are completion rate, so how often you actually got to the cecum. We look at what we call adenoma detection rate, which basically means that our adenoma detection rate should be about 10 or 15%, which means that if you're doing, and it's a sort of indicator, if you're doing too many, if you're doing 100 colonoscopies and not finding anything, then you're probably doing too many. So we're expected to have an adenoma detection rate that's just polyps of 10 to 15%. And we look at our complication rate, so that's the incidence of perforation, and we also measure withdrawal time. So they're the 4 things: completion rate, adenoma detection rate, perforation rate, and withdrawal time. So that's as on an ongoing basis, it would be good for you guys to record those things. So completion rate is very important. And your detection rate, your carcinoma detection rate is 20%, which means that you're only scoping very symptomatic people probably. So completely different to us. And, you know, you're obviously scoping very appropriate patients. As you become more adept at colonoscoping, you'll probably do more patients and your cancer detection rate should go down. But it would be worth just keeping, and you've had no complications, which is fantastic. It'd be worth just keeping track of those 4 things. Withdrawal time is interesting, and that's put out by the Gastroenterological Society of Australia. And basically that's just to stop people doing 1 million colonoscopies and not paying attention. Because if you withdraw slowly, it means that you're more likely to pick up polyps. So you're meant to take 6 minutes to withdraw. So once you get to the cecum, you're not meant to just pull it back like a lawnmower. You're meant to sort of look back slowly and look around each fold and make sure you don't miss any polyps. So I think, you know, those numbers are impressive, and a 20% detection of carcinomas in colonoscopies means that you're doing very symptomatic patients. And the endoscopy, you know, endoscopy is a lot easier and a lot less morbid procedure, but the fact that you're able to do stents there is fantastic. Those stents look beautiful. It is interesting that you've done stents in the esophagus, because you can, a good way to palliate some rectal cancers and some locally advanced colon cancers is stenting. So whoever's got the skills there to stent the esophagus could develop those skills also to stent colon cancers. And we stent colon cancers for 2 reasons. One is palliation. So if someone comes in and they're already full of liver metastases or peritoneal disease, sometimes we'll just stent them to avoid an operation. Occasionally, we'll also stent them as what's called a bridge to surgery. So we can put a stent in, like your second patient. Sometimes you can put a stent in and unobstruct them, and then you can do a more sort of elective procedure. So it's actually, those stent pictures are quite impressive. So whoever's doing the esophageal stents could potentially consider stenting the colon as well.
So can we
who did the stent, Scott? Was that you?
Yeah, I did the stents with Elizabeth.
Is that Elizabeth in the background?
No, that's Florence.
She's not here. She's a physician. We forgot to invite her.
Look, I'd have to disagree with that. I think that stents are very dangerous, colonic stents, and I think that there's definitely a very difficult learning curve, and I think they're no replacement for a good colostomy, defunctioning colostomy. I don't think they're the panacea that they were made out to be when they first came out. But yeah, that's my...
You know, that's reasonable, Gary. That it is certainly debatable in the bridge to surgery thing. It's debatable. As a palliation, they're good. Scott, they're certainly more tricky than doing esophageal stents, because the esophagus is just a straight line. You just go bang, whereas the colon's, you know, a bit more bendy. But it's something to consider, maybe more as palliation than a bridge to surgery. In surgery, you're much better, if you've got an obstructed sigmoid colon cancer, you're much better to do either a Hartmann's or a joint if you're comfortable. But as palliation, they're not bad. And they're very impressive pictures of the stents in the esophagus.
Well done. So I think, Matt, I think that's been a great presentation. It's been a wonderful attendance from Kiribati, Papua New Guinea, Vanuatu. VCH, is that Villa Central Hospital?
That's correct.
Right, okay.
Yes.
Great. Ako Milan from Kiribati. So I thank you all for coming. It's been a good session. We'll put it up on the web if you're all in agreement on YouTube. And I'm hoping to put up an article, Scott, on your endoscopy results in the DAISI October newsletter, if that's okay.
I think that's all right. That's all right.
Great.
Thanks, everyone. So it takes you guys, just one last question. When you did those colonoscopic biopsies, you send them to Brisbane and it takes a couple of weeks to come back. Is that right?
It takes around two to 3 weeks to come back.
Yeah. That does make it difficult with management, doesn't it? Certainly, like the surgeons on the DAISI, myself, Gary, Peter Hewitt, we're always happy to be contacted about individual cases as well. So don't be afraid to give us a ring. It's even intraoperatively, if you are wanting help with decisions intraoperatively and you can get hold of us, we're very happy to talk.
Yeah, there's also an anatomical pathologist, Deborah Smith, who's just started work at Royal Brisbane Women's Hospital. So she may be a useful contact for these sessions to get a quicker turnaround time. So I might have a chat with her and see if we can get her on to the next session. Thank you, everyone. We've gone a little bit past time. So until next time.
Thank you.